Good evening, all. Thank you for this wonderful opportunity. I would like to thank AIOS at the offset. So I'm going to talk about a case of, I'm going to unravel the enigma of lens-induced glaucoma resembling endophthalmitis. This is a case of a patient, 78-year-old male, who presented to us with a history of diminution of vision for last 2 years in left eye, with an acute onset, progressive, painful worsening of vision for 2 weeks. He had no history of ocular trauma or any other ocular surgery, although the patient had a history of pulmonary TB and is on ATT for last 6 months. On clinical examination, the patient has a visual acuity of hand movement close to face, IOP of 40 mm of Hg. Diffuse circumcorneal congestion was present with bogey iris and fibrin. Patient had exudative-like material in the anterior chamber inferiorly, which could be hypopyon or pseudohypopyon. On posterior segment examination, patient just had a yellow glow. We did an ultrasound for this patient and we found multiple pinpoint echo with mild echogenicity throughout the vitreous cavity. However, patient had a normal retinal corneal thickness. So based on the history, the clinical diagnosis and ultrasonography, two diagnoses came to our mind. One is phacolytic glaucoma or the lens-induced glaucoma. Second was endogenous endophthalmitis. So we ordered a UBM for this patient to look at the lenticular status, and what we found was an hyperechoic material in the anterior and the posterior chamber inferiorly with partially absorbed lens and liquefied cortex. And liquefied cortex was seen on UBM as largely echo-free space between the two dotted and a solid line with few echoes. So we revised our working diagnosis to a phacolytic glaucoma. The patient was put on IV mannitol, glycerol, oral acetazolamide, and topical timolol maleate. For the anti-inflammation, we gave the patient prednisolone acetate topically, topical cycloplegics, as well as oral prednisolone. We planned for the patient for 23 gauge PPV with lensectomy, as well as for the cultures. Intraoperative course revealed that this exudate was fluffy in nature and as well as blood tinged. There was partially absorbed lens inferiorly. There were fluffy cortical matter seen in the vitreous with partially absorbed nucleus. In the postoperative period, the patient gained best corrected visual acuity of 6/9 and 14 mm of Hg IOP without any drugs. 9 weeks later, we planned a secondary IOL or 3P secondary IOL in this patient, and patient has a visual acuity of 6/9 partial with IOP 14 without any anti-glaucoma medications. So I would like to conclude is that fluffy deposits with increased IOP is a hallmark of lens phacolytic glaucoma. However, vitreous cells present specifically in the posterior vitreous is suggestive of inflammation like posterior uveitis. Endogenous endophthalmitis usually presents with increased corneal thickness. In atypical cases, UBM can aid in clinching the diagnosis for phacolytic glaucomas. Hemorrhagic pseudohypopyon is a feature of leukemia, lymphoma, and AIDS. So awareness of unconventional presentation of phacolytic glaucoma is pivotal in accurate diagnosis and optimal management. Thank you.
While making a diagnosis of phacolytic glaucoma, you did not mention about the slit lamp examination. What about the AC depth of the case?
So initially, when we examined this patient, I have mentioned that the patient had a normal AC. I have not mentioned that the patient had a normal AC depth, but apart from that, the patient had a yellowish exudate in the. It more looked like an endophthalmitis because of a yellowish glow with multiple AC full of cells-like material. Probably it was a lenticular material that has leaked. We thought it's initially the cells. But because there was a yellowish glow, we thought of endophthalmitis. However, still at that time, we thought this could case because endogenous endophthalmitis has certain other parameters like the patient had an IV drug abuse or something like that. There was none like this. But because of the yellow glow, at the same time, the posterior vitreous having the cortical, these echogenicities, the mild echogenicity suggestive of exudate. In phacolytic, mostly they are associated with the anterior vitreous cavity. So that is why we kept the differential diagnosis of endophthalmitis as a second differential diagnosis, not the first one.
My point is that if suppose we differentiate between phacomorphic and phacolytic.
The AC is going to be shallow.
AC is to be shallow in the phacomorphic, and this most likely was a pseudo-hypopion type.
Absolutely, sir.
So one has
Absolutely.
to be differentiate between a true hypopion and pseudo-hypopion.
Absolutely, sir. Thank you.